Thank you, Ben, and thanks to you and Doug for inviting me out year after year. The main thing is that I be invited out more than Lainey Ross, and I think I'm still one ahead of her. So if I can maintain my lead, that'll be good. I also appreciate the opportunity to reflect on the privilege I had to be involved with the origins of this center. It was probably 13 years ago that Jim Hendricks gave me a call and said he wanted to learn more about how to upgrade their IRBs, is my recollection of what the original project was. And I said, glad to help. I was chair of our IRB at the time. And Jim came out to Madison, spent a considerable amount of time learning what we did, listening very carefully. And then the conversation expanded. He told me about the interest that the Children's Hospital had in developing a pediatric bioethics center. And I said I'd be glad to help with that too, and that led to an invitation to come out here and spend a few days meeting other key people, including Truman Katz, I'll say more about in a minute, and the board of directors. And what I said, it was a very amazing set of conversations, because I said, everything I said, they sort of not just wrote down, but said, yeah, we can do that, we can do that, we can do that. And I said, this is not simple. You can't just have one person, he or she needs colleagues. You're really going to need 2 or 3 or 5 people. You're going to need to have one of these ethicists be head of the IRB, because that's really where the ethics clinic is. That's where you get a steady state. You're going to need a training program. You're going to need to be connected with the university. You're going to want fellows to have young people stimulating you. It's going to take a few $1 million to get this off the ground. But that's no problem. That's no problem. And then I met the board of directors, which at the time was an all-female group. I understand that's been changed, but that was an amazing experience too, sitting in a room having 12 or 15 women listening to me. At home, I have trouble getting one woman to listen to me. And having this dozen or more group of people not just listening, but writing down everything I was saying and nodding their heads and say, yeah, we can do that. It was like a dream come true. And then best of all, when Truman put his money where his mouth was and came up with a substantial amount of money to get this on the ground, and they initiated a national search and looked at really all the best people in pediatric ethics, and wound up with 2 of my former residents. I was head of the residency program when Ben Wilfond and Doug Diekema were training in Madison, and got them to come out. Ben eventually as director, Doug as chair of the IRB, head of the education program, and so on. That was just immensely gratifying and ensured my continued connection with the center. But best of all those memories was meeting Truman, who was CEO at the time. And it's just one of those rare moments when you meet somebody and you just know, as Malcolm Gladwell would say, within a blink, that this is somebody you connect with, somebody who you're thinking on the same level with, and who you resonate with. And Truman did everything he said he was going to do and more. This conference is just, the whole center is just far more successful than I ever dreamed could ever be achieved, and he really gets the credit for it. One of the things I told him and the board is that to have a bioethics center succeed, you need buy-in from key institutional leaders, because you can't have key figures in the institution thinking this is just a bunch of meddlesome people who are annoying us. And what I had in mind when I said that was chairs of major departments. And Bruder Stapleton, the chair of pediatrics, definitely bought in. But you need other powerful figures. But what I never really dreamed was that the most powerful person, the CEO of the institution, would not just buy in, but just have the vision to see that this was a necessary part of a national children's hospital. So Truman and I have often talked about how we both regret that I wasn't able to come out here and head the center, because it's really what I would have wanted to do, but I had other family ties in Madison and so on, and it was at a point in my life where I couldn't move. But that would have been that's the only disappointment I have about the whole thing, because it would have been great living out here and working with him. But Truman, it's always great to see you, and thanks for making all this possible. With that now, let's move to some comments about international research ethics. In 1300 BC, after the inhabitants of Gilead inflicted a military defeat upon the tribe of Ephraim, the surviving Ephraimites tried to cross the Jordan River back into their home territory, and the Gileadites secured the river's fords to stop them. In order to identify these refugees, the Gileadites put each of them to a simple test. Whenever an Ephraimite fugitive said, "Let me cross," the men of Gilead would ask, "Are you an Ephraimite?" And if he said no, they then said, "Very well, say shibboleth." The pronunciation of the Hebrew word shibboleth was used to distinguish Ephraimites whose dialect lacked the sh phoneme, such as in shoe, from Gileadites whose dialect did include such a phoneme. So if anyone said sibboleth instead of shibboleth because he could not pronounce it, they would seize him and kill him by the fords of the Jordan. 42,000 Ephraimites fell on this occasion, unable to use the word shibboleth, to say it. So shibboleth has since come to mean, or to refer to an old idea or opinion or saying that is commonly believed and repeated, but that may be seen as old-fashioned or untrue. Shibboleths are, in the modern parlance, also has come to mean saying something because it sounds good, because it will get you where you want to go, get you to cross the river, or get you into the halls of bioethics and make you sound like somebody who knows what you're talking about. Shibboleths are common in bioethics. Here's just one famous example in research ethics. You can't discuss or write about research ethics without quoting this one, the first principle of the Nuremberg Code, namely that the voluntary consent of the human subject is absolutely essential. Well, this is a shibboleth. It's something that sounds good to say it, but really is quite off the mark, as we all know. If that were true, that the informed consent of the human subject is necessary, we could not have any research on children. We can't get meaningful consent from children. We couldn't have any research done under the waived consent provisions of the common rule, which most people think are a fairly sensible exception. We couldn't have research in emergency settings, such as research on cardiac arrest, where consent from the patient or his or her surrogate is usually impossible. None of this would be possible, and yet all of these kinds of research go on with generally wide acceptance. So to say that the informed consent of the human subject is essential is a shibboleth, and yet it's repeated over and over again, and you see people saying it. What I'd like to do today is to go through 4 or 5 other shibboleths in international research, statements that sound good and that are constantly regurgitated, but which I think are shibboleths and really can't withstand scrutiny. So here's a short list. Number 1, if it's wrong to do a study in the US, it's wrong to do it everywhere. If you do it elsewhere, particularly in a developing country, then you're using different ethical standards. Another one is that subjects in the control group should receive the best proven therapy. That's what it says in the Declaration of Helsinki, or did for much of its life. That if effective treatment exists, that a placebo should not be used. Third, that a randomized trial should be in equipoise. You should be really uncertain about which arm is better. Fourth, that the benefits of a trial should be available to the host country. You shouldn't do research in a developing country just to benefit people elsewhere. And maybe the worst shibboleth of all is this notion that the Helsinki Doctrine is a coherent guide to ethically responsible research, and yet everybody salutes it. The FDA requires you to pledge allegiance to it as a condition of doing clinical trials. So to explicate why I think these are shibboleths, I'd like to go through 2 very famous, or infamous, if you like, studies and examine some of the criticisms that have been made about them. So a shibboleth is an old idea or opinion or saying that is commonly repeated but that may be seen as old-fashioned or untrue. To do this, I'm going to be daring. John Paris tried this at this conference a few years ago. I'm going to try to be to use the methods of Socrates and be a little bit interactive and ask you to participate a little bit just to get some ideas flowing about common ways of thinking about these problems. So I'll be asking a few Socratic questions in a few minutes. My goal is that by the end of this session, you will be in a situation similar to the king of Siam, who famously said, "There are times I almost think I am not sure of what I absolutely know." I don't insist that you agree with me about the points I want to make about these shibboleths that I mentioned, but I hope you will at least be unsettled, that you'll be less sure about what you previously thought about these common so-called truisms. So the first trial I want to talk about is the famous maternal fetal transmission trials in Africa and Asia in an effort to try to reduce maternal fetal transmission of HIV. And to get at that, we need to just spend a few minutes on the background trial that led to the Third World trials, which was the famous 076 trial in the US. So at the time, in 1994, AZT was the only approved drug for HIV/AIDS. Maternal fetal transmission in the US was around 30%, but it's important to note that the range was from 5% in upper New York State. In rural parts of New York State, there were centers, populations in which the transmission rate was only 5%. In Harlem Hospital, it was 40%. AZT had been approved only for patients with clinical AIDS. It had not yet been tested or approved with people who were just HIV positive and had no clinical manifestations. So the benefits and risks for HIV asymptomatic patients was unknown, and the fetal effects were totally unknown, so whether it was safe to give it to pregnant women was unknown. So this trial, called 076, because it was the 76th trial done on patients with HIV/AIDS, was a trial giving this drug to, excuse me, I'll take a drink in a minute if this continues, giving it to HIV asymptomatic pregnant women who were randomized to receive either AZT or a placebo. The regimen involved a daily oral AZT from about the 5th month of pregnancy, a single IV dose during labor and delivery, on the theory that that was a peak time for transfer because of all the blood and broken skin of the baby, and then 6 weeks of oral AZT to the infant. So this was the proposal for the 076 trial, to randomize HIV positive but asymptomatic pregnant women and to randomize them to this AZT regimen and a placebo. So let me pause there and ask if anybody in the room has any concerns with that trial design, ethical concerns. The idea of withholding a, yeah.
One thing, although I understand that AZT was only approved for people who were showing clinical symptoms of AIDS, it does seem like the problem is so serious that in some ways I worry about a placebo group.
Great. So the comment was made that she's concerned, as many people were, that even though the risks of AZT to the fetus were unknown, the risks of HIV transmission was certain death at the time. Virtually all affected infants died, and usually very young. That risk seemed much higher, and therefore given placebo. So what that concern led to was the proposal that, that we just study a large cohort of women and give all of them AZT? A single-arm cohort study. That sound. Say it again. That sounds to me like giving AZT to a large group of HIV-positive women. Well, this was a common suggestion at the time, and it's not just an ethical issue, it's a scientific issue, because here is the design that this woman is suggesting, and thank you for being brave and participating. Forget the placebo part. That would be ethically problematic. Let's just give AZT to a cohort of HIV asymptomatic pregnant women. And the scientific problem that was raised from that, apart from the ethics, is suppose you got that number. What do you, let's assume that was the result of that trial. What do you know now that you didn't know before?
I see your point, but the one thing I would say is, I'm not just saying randomly just pick people. I think you would have to start with some defined population. For instance, if we know at Harlem Hospital that the rate is about 40%, I believe as you suggested retrospectively.
Right.
And we got that number with a group of women from Harlem Hospital randomly selected. Then, I mean, it wouldn't be as rigorous as if we had two arms and we could say, yes, here's your P of 0.05. But
So first, sorry, thank you. So first, I hope it's clear that if you did this study that's on the screen right now, you would know nothing that you didn't know before because you would have no idea what the rate of transmission would have been in that population that you're studying. And what our colleague is suggesting here is, well, maybe if you did it in a defined population where you, quote, knew, end quote, the transmission rate was 40%, then 20% would look pretty good. But so this is using a historical control, and we know that generally in clinical trials, that's beset with all sorts of problems. We later learned that the factors that affect transmission is not just where you live, but many, many things, which could vary enormously in any one hospital. So what your viral titer is turned out to be very important. What strain of the virus you had turns out to be important. When you acquired it, before or during pregnancy, when in pregnancy you acquired it, whether you had associated, particularly sexually transmitted diseases can affect transmission rate, your nutritional status, genetic factors, the mode of delivery, C-section versus vaginal delivery, breastfeeding versus formula. We later learned that that can be an important transmission factor, and then totally unknown genetic factors. So even if we did this study in a defined population, as you suggest, we would have no idea about all these other factors, and that's the magic of randomization, to try to neutralize all those factors. So for all those reasons, and the objections you raised were raised by many thoughtful people, and the suggestion you made was made by many thoughtful people. But cooler heads prevailed, and the study was done as a randomized controlled, placebo-controlled trial, and that trial was stopped before it fully enrolled because the difference was so dramatic, with not a complete ablation of transmission, but a dramatic reduction from 25% on the placebo group to 8%, with a p-value with 4 zeros after it, and 0.7, so the trial was stopped, and 0.76 immediately became the standard of care in the US and Western Europe. So that's the background. But this was a study done in a country that, while HIV/AIDS was a serious problem, affecting 1 in 1,000 people, which is a lot of people, this was child's play compared to the problems in Africa and parts of Asia. So let's just go to Uganda as one of the countries of great concern, in which the incidence of maternal HIV was 40% in some villages and districts of Uganda. 40%, almost half of the women in this country were destined to die, including pregnant women. Giving the 076 regimen to this cohort of women was a non-starter. First of all, the cost of it was approximately $1,000. The total healthcare budget of Uganda was less than $10 per person per year. AIDS was very important, to understate the case, but there were many other crises that they were facing in healthcare. There was no prenatal care in Uganda. Many people, most women did not show up anywhere until they were in active labor. So finding them and getting them to start taking a drug from the mid-trimester on was a non-starter. You'd have to develop a whole new healthcare system. The stigma of HIV was even greater in Africa than in the United States, so the idea that these women would come in and get tested in an American-sponsored trial was wishful thinking. A trial sponsored by the US all by itself made it problematic. So there was a need for an inexpensive, deliverable intervention, and the 076 regimen was not it. So a very bright idea surfaced as a result of subgroup analysis of the 076 trial. Namely, there was a group of women who started in the trial and then dropped out. But they showed up for labor and delivery at the healthcare center where they were getting their care. So they had had a few doses of oral AZT, some for a week or two, some for a month or two, but very variable, and none of them had the whole course. But they all got the IV single dose during labor and delivery. So this later euphemistically came to be known as the short course. And it was noted that the transmission rate was lower in the women who got this short course than in the placebo group. The significance of this is uncertain, as it always is in subgroup analysis, because this was a statistically small sample. You couldn't do meaningful statistical analysis on it. It was possibly a bias sample. Why did these women drop out? Maybe they were richer, poorer, better nutrified, had more or less other STDs. You couldn't tell if they were really similar to the placebo group in the trial. And they received widely varying amounts of oral AZT. So what the subgroup analysis did was generate an interesting idea that maybe a short course, maybe just the single intrapartum dose, might accomplish something, because they at least all had gotten that. So the proposal was to try this short course out in Uganda and dozens of other countries. So this was the proposal, to somehow identify women who were HIV positive and randomize them into a trial in which half would get just this intrapartum delivery. All you had to do was identify them at the time of labor and delivery through their equivalent of midwives, and give this single dose at the time. This could be done in a tent with attentions to privacy, the best standards of consent that could be applied, and see what happens. Does anybody have a problem with this design? Anybody? Yeah. Great. So she said it doesn't offer the best proven available. We have now a proven effective therapy. The Declaration of Helsinki said that that's owed to everybody in the trial, later modified to everybody in the control group. Yeah.
And I appreciate that, but I think the idea here is that it would be logistically impossible to do all the tracking that might be required in Uganda. And so if this would be a way to sort of, if the short course would be helpful and it was something that was feasible in the host country to continue after the trial, then that makes more sense. I mean, in a way, it's like if we test it here and we say, yeah, that's great, it works, but it's never going to happen, that seems even more problematic.
So she's disagreeing with the first woman who correctly points out that this, ethics aside, this is a violation of the Declaration of Helsinki, to which virtually all researchers pledged allegiance. So Dr. Sidney Wolfe and Peter Lurie wrote a blistering editorial in the New England Journal of Medicine, accompanied by an editorial by Dr. Marcia Angel, the editor of the New England Journal, both editorials strongly condemning this proposed design, which was stimulating a lot of public debate at the time, and said that instead, because of this duty to make sure that at least people in the control group got the best proven treatment, this was the design that should have been done. The short course should have been compared to 076. So suppose you did that trial and you got this result. Both groups turn out to have 18% transmission. What do you know now that you didn't know before? It's just as good as 076. Is either of them any good? You have no idea, because this lacks what Bob Temple, the most important figure at the FDA, it lacks what is called assay sensitivity. You just don't know what the rate would have been if people had received nothing. And in fact, if you look at the actual results of the, I'll come to that in a minute. So the problems with giving 076 to anybody in Africa was, first of all, you couldn't do it logistically. It was just physically impossible to change their healthcare system so you could diagnose these women and deliver this drug for mid-trimester. Second, even if you did that, which you couldn't do, but even if you did and it turned out to be better than the short course or even better than placebo, so what? As this woman over here is suggesting, this would be of little or no use to the women of Uganda because it would not be deliverable. You might prove it in a study, you might be able to get enough money to somehow do this study. But if the purpose of a study is to help the people in the population that you're studying, 076 was not going to be that. Bill Gates was not interested in subsidizing a $1,000 regimen that would require change in their healthcare system. It might be useful to women in the US, but that sounds like exploitation of Ugandan women. It would require a much larger sample size, which would take longer to do, and more children would die while you were studying this because of the larger sample size. And in fact, this is a slide summarizing the outcomes of the short course trial. The short course trial was done, that is short course versus placebo, in 20 or so countries, and the results ranged from 10 to 18% transmission in the short course group and 19 to 26% transmission in the placebo group. Not as dramatic as 076 versus placebo, but statistically significant in some centers. And in fact, if I put the actual numbers on the board, you'll notice on your left in the short course group, there were some countries in which the transmission rate, the highest recorded, was 18.9%. And in the placebo group, there were countries in which the transmission rate was, in the population they studied, was 19%. That's no difference. That is, if you did not have a placebo group, you would not know, you might have the same transmission rate with the short course or placebo. So it worked in some places, but not others. And it depended on all these other factors that were difficult to evaluate. So the short course placebo design, which was harshly criticized by these writers in the New England Journal, including the editor, went forward. The criticism of Dr. Angel and Drs. Wolf and Lurie for writing these, the tone of the editorials and the absence of any opposite point of view at the time, having two editorials on one side of the issue and no counterfactual editorial, led to the resignation of David Ho, the Nobel laureate who invented antiretroviral treatment. He was on the editorial board, and Catherine Wilford, who was the country's leading expert on neonatal HIV/AIDS. They resigned in protest over Dr. Angel's and Wolf's and Lurie's handling of that, which led to an invitation to Harold Varmus, head of NIH, and David Satcher, the Surgeon General, to write an editorial providing the rationale. The criticisms of the short course study, as I said, or as was mentioned, were first that proven effective treatment should not be withheld, that it was wrong to use a placebo if effective treatment exists, and that if it's wrong in the US, then it must be wrong in Uganda. These were the main points of Angel, Lurie, and Wolf. Let's just look at those criticisms in a little more depth for just a couple of minutes. This claim that proven effective treatment should not be withheld, or as the Declaration of Helsinki said at the time, and the declaration has been revised many times over its history, but the version that was in effect at the time of these African Asian studies said, quote, in any medical study, every patient, not just the control group, every patient, including those of a control group, if any, should be assured of the best proven diagnostic and therapeutic method. Just think about what that means. Let's just take a much less controversial kind of study. Let's say a pediatrician here at Seattle Children's wants to test a new antibiotic called wundermycin and compare it with the standard of treatment for otitis media, amoxicillin. This would be the traditional way that he or she would set up this trial. This is what the FDA would require, an equivalency trial or a non-inferiority trial with the proven effective standard treatment. But the Declaration of Helsinki says that every patient must receive proven treatment, and therefore what the trial would actually have to be, since everybody would have to receive proven effective treatment, the children, even in the experimental group, the new intervention group, would have to get wundermycin plus amoxicillin. This is a zany way to do a trial. This is a regimen that neither the company nor any sane pediatrician is interested in learning about. Nobody wants to have a double regimen as a first-line therapy for otitis media. And more important, this trial would tell you really very little about what wundermycin alone would do. You would have no idea without having it tested as a solitary drug. So this principle of the Declaration of Helsinki would prohibit almost all clinical trials that had been done in the US and elsewhere over the past 40 years. Moreover, another section of the declaration says that the reports of experimentation not in accordance with the principles laid down in this declaration should not be accepted for publication. This would have prevented the publication of most clinical trials that had been done under FDA oversight of the last 40 years. It would have prohibited publication of the AZT short course trials in Africa. So it not only forces investigators into an untenable scientific position, forcing them to do studies which you can't learn what you're trying to learn, but it prohibits the information from those studies from being disseminated. So this notion that proven effective treatment should not be withheld obviously is problematic. It's important to note that no one in the short course trials was deprived of treatment as a consequence of the study. Women in the placebo group did not get any treatment, but that wasn't as a result of being in the study. They would not have received treatment whether they were in or out of the study. So the study didn't result in anybody being worse off than they would have been without the study. Maybe if there's to be any kind of principle, it should have say something like that no one should be deprived of available proven effective treatment. But as we've seen, even that would be a problematic principle, as the otitis example suggested. The criticism that it's wrong to use placebo if proven treatment, effective treatment exists. Again, a placebo group was not deprived of treatment due to being in the study. There was no risk of harm of being in the placebo group. You might be harmed, your child might get the disease, but it would not be as a result of the investigators who are being in the study. The women in the AZT group might be harmed, or their babies might have been harmed, but there were high standards for consent as best could be achieved in that population. That is, nobody was deprived of information, and they presumably joined the study willingly. And then this final criticism that if it's wrong in the US, then it must be wrong in Uganda. You certainly could not have done the short course trial with a placebo control in the US. It would have been clearly ethically problematic to withhold proven effective treatment from women in the US for whom 076 was widely available, paid for by Medicaid. And this parallel claim that Dr. Angel made that if you do a trial in Uganda that you would not do in the US, you're using different ethical standards. Well, the ethical standards are the same, and this is the key point, but it's the facts that are different. And as the title of this talk suggests, when you see studies being done in the third world that are ethically indefensible in the US, or at least problematic, it's not different ethical standards in the two places, it's different facts on the ground. What are the ethical standards? Well, Zeke Emanuel and colleagues have written an excellent series of papers on what makes research ethical, including a paper on what makes international research ethical. And here's his list. It's one that I think everybody subscribes to, including me. There should be a collaborative partnership. Any research should be involve not just the investigators, but the population that's being studied. The research must have some social value. It should be important. Must have scientific validity. Should be designed in a way that you can learn what you're setting out to learn. Should be fair selection of subjects, favorable risk-benefit ratio, institutional review, high standards for informed consent, monitoring for adverse events, publication of results. There are a couple of others, right to withdraw and so on. All these principles were followed in the African AZT trials. The ethical standards were exactly the same if these are your ethical standards. What was different was the facts that made it inappropriate to do that study even by these standards in the US because these criteria would not have been met. Now, let's move on to a second collection of shibboleths in the Declaration of Helsinki and cited elsewhere, raised by a different study, much more difficult than even the ethical issues raised by the AZT trials. So the Declaration and other international codes of ethics all say pretty much the same thing on this point, namely that medical research is only justified if there is a reasonable likelihood that the populations in which the research is carried out stand to benefit from the results of the research. And at the conclusion of the study, every patient entered into the study, including those in the control group, should be assured of access to the best proven prophylactic, diagnostic, and therapeutic methods identified by the study. Well, it's a little unclear why this is a requirement or should be, but the value of this principle, or the coherence of it, was dramatized by a infamous, if you will, highly controversial for sure, study involving a form of surfactant called surfactant. So as background for this, surfactant is a chemical that improves outcomes for hyaline membrane disease, also called respiratory distress syndrome, which is probably the most common cause of death in infancy in the United States. The most common cause of death in infancy is prematurity, and the way prematures die is mainly from premature lung disease. And surfactant, due to inability to manufacture surfactant at early gestational ages, and this can now be made in a factory and sufflated into the respiratory tract with improvement in outcomes. There were several different forms of surfactant. This is a very large worldwide market, and so several companies were interested in having their own Me Too versions of surfactant to get part of this market share. And a US company called Discovery Labs wanted to join the party and sought to get part of this market with a new version called surfactant. The FDA insisted on a placebo-controlled trial, which they virtually always do, even with a very serious life-threatening disorder. And the reasons they do is mainly because of Bob Temple's insistence that this problem of assay sensitivity leaves you in the dark if you don't have a placebo group. So for rightly or wrongly, surfactant could not get the FDA to consider this drug without a placebo-controlled trial. Doing it in the US was a non-starter. No US investigator was willing, appropriately, to withhold proven effective treatment from children with a life-threatening disorder. So it was considered unethical in the US to do that. But in countries like Bolivia, where there was minimal availability even of neonatal intensive care units, inability to afford surfactant, the healthcare budget of Bolivia at the time was about $100 per person per year. So this was a drug which was largely non-deliverable in Bolivia. The investigators, the sponsor, the Discovery Labs, saw this as an opportunity to do a placebo-controlled trial in a country where they thought it could be ethically justified. So the proposal was to find a group of premature infants with respiratory distress syndrome in Bolivia. They would all get Cadillac NICU care. That is, what the company would do would be to build an ICU that was state-of-the-art, staffed with highly trained people who they would train, arrange a transportation system, helicopters, and so on. So everybody in the study would get standard of care that was, or a level of care that was far above what they would have received without the study. And half of them, in addition, would get surfactant. So the design was NICU plus surfactant versus NICU plus placebo. Does anybody have a problem with this study, with the design of this? Yes, ma'am. Glad to have at least one foil. Yeah.
Well, my one issue with you is the following. I think it's not so much, I can see their point. What I think you have to think about is the long-term outcome. So let's say we find out surfactant really works. Is that really just going to become an issue so I can get FDA approval and make money in the U.S.?
That's exactly it.
It's great to put infrastructure in place with the study, but like, are we going to make surfactant available to Bolivia? That would have less of a problem with it if that was the end goal, kind of like the short course in Africa.
She said her problem is not so much with the design of the study, but with the aftermath of the study. If surfactant was not going to be available generally in Bolivia, that this would be some sort of exploitation. And that's exactly what the sponsor agreed to. I mean, he acknowledged that it would be unlikely that the country of Bolivia would have the money to do this generally, because it wouldn't have the NICUs. she says that even if it were available generally in Bolivia, you don't know if it's going to work elsewhere in Bolivia. That's a problem with all clinical trials, because you can't do a clinical trial on everybody in the population or every village and town in the population. So there are always going to be questions about generalizability. Armand, one more comment.
So why is the FDA only willing to accept a randomized placebo-controlled trial as opposed to a non-inferiority trial?
Dr. Anna Maria is asking, why did the FDA insist on a placebo-controlled trial? We don't have time to go into all that. There is a coherent answer, and it's related to the one that, for various reasons, an equivalence trial or a non-inferiority trial, Bob Temple thought, would not give you the information. That it had a high risk of producing misleading or useless information. But in the readings, there is a reference, I think, to Bob Temple's long article about this, providing a detailed answer to that question. So there is at least a coherent answer. So the trial was done. The suggestion that it be done without a placebo group had the same problem that the AZT trial had, namely if you just took a bunch of premature infants and put them in a NICU plus surfactant and they did better than historical controls, you would have no idea whether this was due to the NICU, which was a new thing for most Bolivians, or due to the surfactant, because you have two interventions. So you needed to control for those factors. So the study was done with excellent neonatal intensive care plus surfactant. Everyone in this study had not just a reasonable, but a likely prospect of being better off. That is, even if you're in the placebo group, your chances for survival were going in thought to be higher because you were getting Cadillac neonatal intensive care, which you otherwise would not have gotten. No one would be worse off as a result of being in the study, unless surfactant turned out to be risky, but that's true of all studies, and there were high consent standards. There would be infrastructure benefits for the country. There might not be surfactant for Bolivia, but there would be now a functioning ICU. There would be physicians trained in this. There would be a transportation system. There would be new jobs. It would put Bolivia in a position to do other studies in neonatology from which they might reap further benefits, studies that might be of greater use to the citizens of Bolivia. So there were indirect benefits. One way to think about this is to compare it to a more common phenomenon in this era of globalization. Namely, what if Toyota had proposed to build a factory in Bolivia and assume the following, that this factory would create many jobs, maybe 1,000 new jobs. There would be generous wages and benefits far above what would have been available to any Bolivian heretofore. There'd be safe working conditions. There'd be an increase in employment and expanded infrastructure, roads, restaurants, healthcare for the employees of the factory. Assume no one in Bolivia would get a Toyota other than the prime minister and his cronies. And assume that the factory closed after 2 years. Once that model of the Toyota had run its course, Toyota said, we're going elsewhere to build factories elsewhere for different reasons. Maybe we can do it more cheaply elsewhere. So here you have an intervention in a country that produces some short-term benefits to those people working in the factory, but no benefits to the people of Bolivia other than this development in some infrastructure. Many citizens would be better off during the life of this factory. No one would be worse off. There could conceivably be an accident in the factory, but they were willing to take that. So is this wrongful exploitation, or is this a good opportunity for at least some Bolivians? And if you're the prime minister of Bolivia, do you say no to this kind of exploitation, or is this something you seek out to at least one factory at a time, try to improve the well-being of your citizens? And more importantly, is this different? If you're okay with the Toyota factory but not with the surfactant study, are these good? Is this a fair analogy, or is the Toyota story different from the surfactant story in a morally important way? How might it be different? Well, some people might say that physicians have obligations to patients that car manufacturers do not have. First of all, the sponsors of the surfactant study were not physicians. They might have been had MD degrees, but probably not. The CEOs of these companies are often not MDs. But even if they do, they're not acting as physicians when they do studies. They're acting as researchers and as Steve Joffe, who you'll hear from later, has written eloquently with Frank Miller and others. A researcher is not a physician, and a researcher's obligations are different from those of a physician. The company sponsoring the Surfactant trial had no clear duty to fix the healthcare problems of Bolivia. It's not clear why they should be responsible for solving Bolivia's problems. They do have clear duties to their shareholders to make money. They have duties to the subjects in the study, the ones outlined by Emmanuel and others, which were fulfilled. They were completely adherent to the widely accepted principles of ethically responsible research. Well, the claim is still in the air that exploitation is wrong, that taking advantage of Bolivians to help Americans or other people in Western society is wrong, and that undue inducements are wrong, that offering this ICU is an inducement that turned the heads of these Bolivian parents to something. It was an offer they couldn't refuse, and that this kind of undue inducement is wrong. I just want to say a few words about these shibboleths, that exploitation is wrong and that undue inducements are wrong. And we just have a few minutes left, so I will just make these points briefly. That is, the claim was that the Toyota factory was not an undue inducement because you could decide or not decide to work in the Toyota factory, but if you're the parent of a sick preemie or if you're in premature labor, you can't decide not to go to an ICU. It's an offer you sort of can't refuse. Well, as Alan Wertheimer has written most eloquently, exploitation is one of these shibboleths that really requires re-examination. Exploitation is not implicitly wrong. Exploitation is ubiquitous, widely accepted, and appropriately so in all societies. Physicians exploit the fear and suffering of their patients. I'm a pediatrician. You bring your child to me with a fever and a headache. You're terrified that he or she may have meningitis. I exploit that fear by doing a good history and a physical and making appropriate care. I make money, not a lot of money, but more money than I actually ever dreamed of. And there's nothing wrong with me exploiting your fear in that way if I do it in a way that's otherwise ethically responsible. I do a good history, a good physical, I'm honest with you, and so on. Cancer researchers are even worse. They take patients who are dying, who are terminally ill, and exploit this horrendous fear of not just death but suffering to recruit them into studies which will promote the careers of the cancer researcher, get him or her money, promotion, trips like places like Seattle, and advance his or her career. There's nothing wrong with that if he or she does that in an ethically responsible way, follows the rules. In fact, we want people in academic centers and elsewhere to exploit suffering cancer patients to advance knowledge about cancer. All blue-collar work involves exploitation. The person who owns a coal mine in an area of wide unemployment, such as Appalachia, is exploiting the poverty and the suffering of people in Appalachia by inviting them to work in a hazardous place for relatively poor wages. We require that the mine have at least have some standards for safety, but we don't say it's wrong to open a mine in such a place if it's run by acceptable standards. So the issue is not whether anybody's exploiting anybody. The issue is whether this is wrongful or unfair exploitation, whether the employment has a fair wage or not, or other benefits. In fact, limiting payments for research subjects or workers is what is really exploitative or wrongfully exploitative than high payment. That is, we have it exactly backwards. Elsewhere in life, what are called, let me just say a couple words about undue inducements and then we'll close. So Zeke Emanuel again has referred to this concept as nonsense on stilts. That is, if by an undue inducement we mean something that would lead a person to do something that he or she otherwise would not do. I'm not going to work in that coal mine for nothing, but you give me money, then I'll work in that coal mine. To say that this is an undue inducement because it leads somebody to do something that he otherwise would not do is nonsense on stilts. The purpose of an inducement is to change behavior. That's what an inducement is. So if it's wrong to offer somebody something that will change their behavior, then all inducements are wrong and all pay is wrong. We shouldn't pay anybody to do anything because it leads them to do something that they otherwise would not do, whether it's a coal mine or a construction job, or to be a research subject. What's problematic is when the inducement is not proportional to the risk. That is, minors getting low wages is what's more problematic than high wages. The moral problem is not if you offer him $1 million, and he says, everybody wants to work in that mine. The problem is if you offer him $8 an hour, him or her, then you have something that is morally problematic. In the military, it's called combat pay. They get it, that if you're asking a soldier to expose himself or herself to higher than normal risk, they should get greater reward, not less. And the view of many IRBs have had this backwards for decades by buying into this shibboleth that undue inducements are wrong. That is, things that lead people to join a study which they otherwise would not join but for the money. If we think it's wrong to give coal miners low pay or combat soldiers, then why shouldn't research subjects in risky studies be getting more money, not less? And I'm proud to say at our IRB, we broke records for tolerance for high pay. We had one clinical trial, a non-therapeutic clinical trial, in which subjects got $13,000 for joining a very uncomfortable and slightly risky trial, one that we thought the risks were at least within the range of acceptability. So the problem in Bolivia with Surfactant maybe was that people weren't getting paid enough to be in the trial, but they were getting a tremendous benefit. That is, everybody in the trial, including the control group, was getting a huge benefit, which was first-rate intensive care with at least a very good likelihood of being better off than they otherwise would have been. In closing, just because everyone agrees with a statement doesn't mean it's true. And the 5 shibboleths that I put on the screen at the beginning are statements that, if not everybody, at least the overwhelming majority of people in the world and in bioethics seem to agree with. Research ethics, particularly international research ethics, has been burdened with these shibboleths, repeated in numerous guidelines, codes, and articles, distracting attention from critical thinking. Unlike the shibboleth in the days of the Ephraimites and the Gileadites, where saying the word didn't cause any harm, pronouncing shibboleth correctly there got you to cross the river and get safely to where you wanted to go. In the modern era, these shibboleths do cause tremendous harm, because by repeating these things over and over again, it makes it very difficult to do studies that are in the great interest of people in the developing world and elsewhere. The Lurie, Wolf, Angel shibboleth, that if it's wrong here, it's wrong there, had it prevailed, would have prevented the saving of what has turned out to be millions of lives with a very safe and reasonably affordable intervention. So reciting these shibboleths in the modern era, unlike in the ancient Middle East, is often to the detriment of many people. Using the standards of ethically responsible research does not imply the same response to a study in different settings. Good ethics starts with good facts, and if we stick to the standards outlined by Emmanuel and others, we'll be on the right path. For those of you for whom this is very upsetting, you can only agree with the person who said, if all the ethicists in the world relate end to end, it would be a good thing. Thank you very much.